All right, we're going to get underway. Good afternoon, everyone. Welcome again to Marquette University Law School, Eckstein Hall. I'm Mike Goucher, and this is On the Issues. This is our continuing series of conversations with news and policymakers, people we say are doing interesting and important work in this region and beyond. Today, we are joined by the President and CEO of Children's Hospital and Health System, Peggy Troy. Many of you in this room are familiar with Children's, but we'll say a couple of things for the record. Children's employs about 5,000 people. It's at about 50 sites around the state of Wisconsin. It's a billion dollar company. About 1,000 doctors are at Children's. So it's a big deal, and we're going to talk today about Children's Hospital, its mission in this community, some of the health disparities in our hometown, and they can be fairly jarring at times. And we'll talk a little bit about healthcare today, the healthcare law, maybe alternative ways of delivering service, Peggy's background as a Marquette person and her experience in the nursing school and how that led to the person she is today. We have a lot to talk about. So won't you please welcome Peggy Troy to Marquette Law School.
Thanks.
I should also say for the record that Peggy Troy is a trustee on
Yes.
the Marquette University Board of Trustees, because she is a good grad. She's, proud of where she went to school. So.
Never thought when I was sitting in the union as a student that I'd come back to be a trustee at Marquette University, so it's a real honor to be part of Marquette.
Let's talk about the mission of Children's Hospital. Let's begin there. Back in 2010, you folks adopted a mission statement that's pretty simple, and I hope I'm quoting it accurately, but you want to have the kids in Wisconsin be the healthiest kids in the nation.
Yes.
Why did you do that? It's an interesting mission statement for a hospital.
It's very interesting because most hospitals want to deliver the best health care and have the best outcome. But we really stepped back and looked at data, and we said, okay, what goes on with kids, the lives of kids in the state of Wisconsin? I just moved here from Memphis, Tennessee, on the Mississippi border. And one of the things coming back to Wisconsin that shocked me was when you drill into the central city of Milwaukee, we have some of the worst health disparities in kids in the country. In fact, we're ranked the 4th worst in the nation. Well, I thought I'd seen the worst of the worst being on the Mississippi and Alabama border with places that didn't have potable water, et cetera. So I was very surprised to come back here and find out that we did have the level of health disparities in kids, and measured on many different data points, whether it's child abuse rates, asthma rates, lack of immunizations, et cetera, et cetera. So when we thought about Wisconsin, and Wisconsin measures to be about in the 50th percentile for health outcomes, as I said, the central city, and we think about what it takes to continue to make Wisconsin a great state, it's easy to know that healthy kids are the future. If they can be healthy, productive citizens who are resilient and have jobs, that really does continue to be prosperous for the state. And because of what we do at Children's, we realize that we have the ability to impact kids beyond being sick. And so that's when we stepped back and said, okay, this is our North Star. This is what we're going to strive towards every day. And it is a little bit different in that where you make your money is when kids are sick and in the hospital, right?
Right.
So stepping back and really creating that. So now the decisions we make, the services, the programs, are really aligned around that vision. And it's adopted by our Board of Trustees. They're some of the best leaders in this community, and they hold us accountable to that.
And I think you said at one point there was sort of an incongruity there. You come back to Milwaukee, you see the Calatrava addition to the Art Museum, you see all the growth that's happening downtown. There are a lot of things going on here that would seem to say this is a very healthy community. That made the disparities even more jarring.
It made it jarring to me. I was incredibly surprised. And again, it was the data that really pointed that out. And as I started to look at what the causes were and what really is happening, it really was very surprising to me because the rates of poverty in this central city of Milwaukee are some of the worst in the country. And poverty is the root cause. I mean, that is one of the major drivers towards health disparities.
So let's talk about a couple of examples of things you saw and maybe the work that's being done to address them. Immunizations. When you came to Milwaukee, what was the rate of immunizations?
So the rate of immunizations in the central city was less than 50%. And so when kids are not immunized, not only do they have greater risk for communicable diseases, but it is an indicator of access to health care. because we know that if kids do have access to health care and they do get their immunizations and their well baby checks, their health outcomes are definitely going to be better. So that immunization rate was one of the things that really just struck me. The child abuse rates. We have one of the most robust child abuse prevention treatment programs in the country. We see over 7,000 kids a year that come through our doors that have been victims of child abuse and neglect. Well, and I hate to say this, but that's just the tip of the iceberg. We're only seeing what's reported, and there's many more. And so when you think about kids and how they grow up, and you think about adverse childhood events, childhood abuse is right at the top, and it affects their ability to grow and develop and become resilient if untreated, because these kids that are living in the traumatic situations that they happen to be in prevents them in many ways from being those productive citizens.
I want to get into that whole issue of trauma in just a moment.
Yeah. Infant mortality.
Infant mortality.
Is another one, when kids are dying in the first year of life. And there are many causes for that. And a lot of it's that lack of access to care. A lot of it's the health of the mother. We know that the health and outcome of a baby starts to be determined preconceptually. It's not just during conception or after they're born. And so that was another huge trigger, that infant mortality was as high as it was.
I want to go back to immunization, though, for a moment, because you've had success in addressing that. I mean, you're not where I'm sure you would want to be, but tell us what has changed and why did it change? That's the real question. How were you able to change the numbers?
A couple of things. One, within our own walls, and particularly as kids came to different clinics and things, we did not, at Children's Hospital, I'm embarrassed to admit this, actually immunize kids if they were not up to date. We sent them to the health department and said, oh, well, you can go over there. Well, we know that if you've got the kids in your care and you take care of it right then, the chances of them being able to be immunized is going to be much greater than saying, okay, well, you can go over to the health department Monday through Friday, 8 to 5. Because remember, the parents that have kids that aren't being immunized often lack transportation, access to good food, good shelter, and things like that. So within our own system, we had to develop an infrastructure where beyond just the primary care offices, but in the emergency department, the ICUs, wherever they happen to be, shoot them up. It's time to go. So it was, and that was what I kept saying, we're going to get these kids and we're doing it. But then the other thing is, and this gets back to part of the community issue, we then started to study zip codes and where the greatest disparities in access to health care were in the central city. And we came down to about 4 zip codes of where we realized that, boy, it was a desert. It was a food desert, a desert for health care. And so we started to meet with the neighbors in those communities and talked about what was happening. What do you want? What do you need? What's there? What's not? We also looked then in those same 4 communities, who's already doing good work? Because if you look at health outcomes in people, and this was another shocking statistic for me being a healthcare delivery person, but only about 20% of your health outcome is determined by medical care. It's really 40% is your genetic profile. Then on top of that, it's the choices you make and where you live.
Really?
And so when you think about that, we know that these kids that are living in these stress situations, we can do some things for them with their families, but we can't do it all because we are healthcare delivery. So we found in the Monty Heights area, we went to the Children's Outing Association. In Metcalf Park, we went to the Next Door Foundation. In Lindsay Heights, we went to the YMCA because they deliver a whole suite of services that we don't. So I'll tell you about the Children's Outing Association. And so they have, so if we're seeing kids there, and actually the Marquette Nursing School helps us staff that. If we see kids there and they're diabetic, well, they've got a cooking kitchen and a gym. And so they can teach the families how to cook fresh food and work with diabetic children, and then also cook the food. So we intentionally then went to those neighborhoods, put clinics in those neighborhoods with our healthcare professionals in the Marquette College of Nursing, and that led to an increased immunization rate because those kids in those communities then now have access to some of the best medical care they'll ever get, not only just in primary care and prevention, but everything else that Children's has to offer. So we're trying to push it out and give kids health care before they become sick.
So you've gone from about 50% to what's the current rate?
We're up over about 68% now.
Okay.
So, and it doesn't sound like a lot, but when you do the statistics over the numbers of kids, it's better. And we still got a lot of work to do.
You know, another area of success is with teenage pregnancy.
Yes. Yes.
That's encouraging. I mean, that's the United Way working with a number of different institutions in this community and community groups to really change something that has a profound impact on a community.
Profound impact, because we know that babies born to teens have a much greater risk of prematurity and a greater risk of just poverty and all the things that come by way of that. So, and that was a community collaborative that was just amazing, because several agencies came together to work intentionally, funded much by the United Way. But what they do, and it's beautiful, is they go out and then find the agencies that actually can have an impact, Pearls for Girls and others, to make sure that we're just driving towards that agenda, and it's statistically significant in terms of the numbers of kids having babies.
Infant mortality, that is a tough one
It's
in
a
this
very
community.
tough one.
Why is it so tough?
Well, it has a lot to do with the conditions that pregnant women find themselves in. So I'm going to give you an example. One thing that we have at Children's, and I don't think it's very well known, is we have an insurance company called Children's Community Health Plan. We insure about 134,000 people, first dollar, it's Medicaid only. About 88,000 of those people are kids, but the rest are pregnant women and childless adults. And so what we know is that the living conditions that women find themselves in, even preconception, has a big role leading to infant mortality. And so and many of these women are homeless, right? They don't have a place to live, so you can imagine access to nutrition and food and some of those other kinds of things is very difficult. So we can tell you that if you're enrolled in our health plan, and we have about 100 of the most at-risk women at any given time, and that means many of them are homeless. Well, we wrap ourselves around them, and they may have a phone call or a visit from a caseworker 7 days a week, just to make sure that they have all their needs. We have a 92% term delivery rate in those families. And it goes to show, so a cost of a premature baby, north of $1 million. For this program, a couple $100,000 maybe, and these families are then delivering healthy babies that then can grow up and be okay. So it's wrapping ourselves around those families and really giving them what they need will lead to that better outcome. And it's been proven over and over again.
You touched on this, and I'd like to explore this a little bit further. The issue of trauma and its long-term consequences for our community. Some people in this room know the law school helps fund journalism projects in this community on important topics, and we were fortunate to partner with the Milwaukee Journal-Sentinel reporter John Schmid recently on a series that appeared in the paper. You may have seen it. It was called A Time for Healing. This series looked at the impact of trauma. It's prevalent in our community, and it has long-term repercussions. You see this. Your hospital sees this. Describe for us your perspective on this issue.
Well, what we know now about trauma is that the impact to people long-term is definitely very significant. And so there's a measurement system out there called ACEs, Adverse Childhood Events. And so when you go in and look at a child's life and you look at poverty, you look at crime, you look at what's happening in the home, what's happening in school, you get a scoring mechanism, and over a score of 4, you know that you've got significant trauma in a person's life. Well, the interesting thing about that we've realized now through scientific studies relative to brain development is that that unresolved trauma that happens early in life, and we're talking preconception, if it's not corrected by age 7, a child actually has permanent brain damage. In terms of its overdevelopment of your fight, flight, and underdevelopment of your judgment and reasoning. So when you look at these kids that end up in juvenile justice or leaving these lives of crime, what you realize is that their whole anatomical, physiological brain is wired in a way in which that drives their behavior. And so as we look at the poverty and we look at the incidence of violence in these households, these kids that are growing up in these very impoverished situations are set up in a way in which it can be irrecoverable. And that's then what leads to a lot of the problems that we see, the manifestation. I've been asked at a point in time to get involved in the issues of juvenile justice. Well, in my opinion, by the time a child ends up in juvenile justice, it's late. It's late. You can do some corrective things, but where you really need to start to back up is in these situations in these early developmental years of these kids. I mean, if you're living in a household with gunfire and abuse and drugs and all those other types of things, the chances of you being successful are very low.
Any ideas on what the community can do to address this now that we're beginning to learn more about the magnitude of the problem?
Jobs. I mean, and when you read the articles, and hopefully you've had a chance to read the series, I mean, we're in the fourth or fifth generation of poverty because, many families moved here because of manufacturing positions, Alice Chalmers and others. When those went away, unfortunately, there was not a replacement. And so many people now are in 4 and 5 generations of poverty, and the cycles repeat themselves. And that's, to me, one of the most important things we can do is develop services to help ourselves wrap around these people, but jobs.
One of the interesting things that you've mentioned is Children's is involved. Many people probably have this image of Children's as a place where they do amazing surgeries to save kids' lives, and that is part of what you do. But you're involved, as you said, you're treating kids who've been subjected to child abuse. You're involved in adoption, in foster parenting. Describe for us Children's role in that.
Well, so I'll start way back. So in 1894, some women in this community, actually 7 sisters, realized that there were different ways to take care of children than just in an adult sort of framework. And so that's where Children's Hospital got started. We had a little house on Brady Street, 4 beds. But in the meantime, about 1892, there was an agency called Children's Service Society that was developed as a foster care and adoption agency. And it actually was a minister who went around town with a horse and a cart and picked up children who were orphans on the street. And our 2 agencies worked side by side for many, many years. And in the late 90s, Children's Service Society ran into some financial difficulty and approached the leadership of Children's and said, can you help us? And it's many times our kids. It's the same kids we see, so we took it over. So now we foster care case manage 3,000 kids. And we also, so one of our major goals with foster care is to get the kids into adequate home environments, and then also, if they can't be reunited with their families, to have them adopted. And so we have about a couple hundred kids a year that end up being adopted of the 3,000 that we case manage. And if you look at who's vulnerable in our society, the one group I think of very often is foster children, because they've been obviously in situations where their families can't take care of them for whatever reason. The average number of homes a foster child lives in is 4. So you can imagine the disruption in those kids' lives and what that really means to them and how they grow up. Many foster families are wonderful and the kids do well. I think the interesting thing that happens is when you reach your 18th birthday, you are no longer a foster kid. There is no longer a stream of money, and many of these kids end up on the streets because there's no place for them to go. So we also have another part of our organization that starts to ready when we know these kids are going to be in that situation to help them find livable situations, jobs, et cetera, so that they can live a fulfilling life.
Has there ever been, and you can share what you want about this, but discussions within the hospital about what is our role? Because you're talking about, this is a broader mission statement than probably some people would prefer. I would imagine there's a little back and forth on that.
Oh, that's one of the interesting parts of my job, because there is some back and forth, because obviously funding and revenues and where you place your emphasis. I mean, if we're blessed in this community to have a hospital that no child ever needs to leave the state of Wisconsin for the highest level of care, whether it's complex heart surgery, whether it's cancer treatment, et cetera, et cetera. We're blessed to have that here, because in many other states you don't have that, and families have to travel, which you can imagine is very disruptive. So we need to fund that, right? And 54% of our revenue is Medicaid, and so our largest payer is the state of Wisconsin. And so it pays you about 80% of your costs, so we have to balance those revenues. And then we have all these other things that we're doing. And the one interesting debate is, how much do we invest in the community? Many of our programs are grant funded, but many are not, and so we are making investments. Well, that's where the North Star really helps us out, because if you want the kids of Wisconsin to be the healthiest in the nation, you want to be the best fixer-upper shop, but you also want to invest in their well-being. And so we drive funding in a very positive way towards that. Phoebe's on our board of trustees. We have those discussions often, because it's important in our situation to keep that North Star as our guiding post. Where it really gets interesting is the health plan, because if we're insuring these kids, obviously the less money you spend in an insurance company, the better you do. And so, but when you've got kids that are really sick and in ICU, that is your revenue base for your institution. So here's the debate. And it's not really a debate because we do it, but if you have a child that is living in a household and the child has asthma, and they go 3 places after school and they need an inhaler, do you do what most insurance companies do and give 1 inhaler, and when that inhaler is used up, you can get your second one? Or do you give that child 2 or 3 inhalers so as they go different places after school, they have it available? Well, it doesn't cost much to give an inhaler, and it's better for the kid, but where you make your money is if the child comes through the ED and they're in the ICU with a tube in their throat on a respirator. Now, we're always going to do the right thing, but it's an interesting conversation.
Another interesting conversation happening right now is the future of the nation's healthcare law. And I'd like to delve into that to some degree here. Speaker Ryan said yesterday that they seem to be getting closer again to having another another piece of healthcare legislation ready to go. We'll see how soon that happens. But I want to get the perspective of Children's Hospital as someone in this arena. What concerns you most about the discussions? What do you feel absolutely has to be a part of any future healthcare law?
Well, a couple of things. One, I mentioned that 54% of our revenue stream comes from the state of Wisconsin. And Medicaid is a program that has many different attitudes and beliefs. And I think one of the common ones is that Medicaid is people who are lazy and don't want to work. And the fact of the matter is, if you look across the country, and particularly in the state of Wisconsin, about 50% of the million people covered by Medicaid are children. They use about 20% of the money or less. And the investments to keep kids healthy are really pretty modest by comparison. The other components of the program are senior citizens who live in nursing homes, blind and disabled. And so when you look at the buckets of how the money flows, there's some sobering times I think we're going to face if the plan that is proposed as of a couple weeks ago moves forward. So the thing that there are a couple of things. One, there is in that current legislation about an $840 billion reduction in Medicaid spend by the federal government. Right now, the way that the formulas work is that the state sends up about a third of the money, and it's about $7 billion a year in the state of Wisconsin, and then the feds match. Well, it's not $7 million, but the total Medicaid program is $7 million. So a third of it comes from the state, goes up to the feds, they match it 2/3, and then it comes back. Well, if $840 billion by 2026 is removed from the federal government, then there's going to be significantly less money coming to the states, and so the states are going to have a real hurdle funding the $7 billion that it costs for the Medicaid program today. The other thing that has been thrown around that is very concerning to me is the whole notion of essential benefits. So what they're saying is, let's give the money to the states, and it's called a block grant, and we'll use some formula to block grant that money. But what we want back is all the regulatory aspects that would be considered essential benefits, so covering pre-existing conditions, immunizations for kids, coverage for pregnant women, et cetera, et cetera. And so the states would get to decide what benefits they want in their program, and there's no baseline. That's very concerning to us because, at least for us, the early and periodic screening program, which is very inexpensive to run, which guarantees well baby visits and immunizations, et cetera, for kids, the states would have the option of taking that away. And maybe Wisconsin wouldn't, but maybe they would. They're also considering a block grant, so that, and the formulas for how that would happen are very concerning. Right now, they're saying it would be on a per capita basis. It's very technical, and I won't get into all that. But if it's on a per capita on today's dollars and doesn't have an escalator for the future, that's also very concerning. And the most concerning thing for me personally is the way that it works for kids right now is there are actually 2 different aspects of Medicaid. One is Medicaid managed care, that's just the traditional stuff. But then the kids that have chronic illness are put into with the chronically ill and disabled. So we really don't have a way nationally to look at what is the true spend for kids. What we're trying to propose is that we put kids into a bucket and let all the dollars that help kids be recognized, categorized, and then have us incentivized to do things like well baby checks and those kinds of things that we know are going to keep kids healthy. So it's the funding formulas, it's the program design, it's the aspects of block granting that really, and again, if you think about 50% of the enrollees are kids, they use 20% of the money and they don't vote. So where's the money going to go? And so for somebody who depends on Medicaid, it's a very sobering time.
The bottom line is you're concerned that unless we're careful, kids get hurt in this.
And if you've read anything about healthcare reform or repeal and replace, you don't hear mention of kids at all. And so with my 220 colleagues across the country, we're really trying to get the message across that there is a fix for kids and it doesn't have to be more expensive, but it's very important because if you look at the future of the country, who's going to work?
I want to talk about the larger issue of competition in healthcare today. We see that playing out in our state, certainly. We see Aurora growing. We've seen Ascension move into this market in a big way. You're out there.
I am.
How does the competition affect you? How does it affect the future of Children's Hospital?
Well, that's a great question. And several years ago, the CEOs of the health systems in the community basically said, you know what, we're going to compete, but we're going to let Children's do its thing. And so that's how, in a very small market, we've been able to become what we've become for this community. Because like I said, if you compare other similar size communities, kids have to leave their communities to get some of the highest end care. So with 5 million people in the state of Wisconsin, 1.5 million kids, most kids are healthy, we've really got to draw on the whole state in order for us to be successful in doing the things we do. And so as the healthcare momentum is moving forward, you hear people talking about managing populations of people. Everybody's trying to work on insurance solutions. And so the notion right now is own the family. And so what's happening is that some of the pediatric care now is being delivered in other health systems. To what degree is still untested. But then what happens to us is our ability to really care for all levels of kids becomes somewhat eroded. And I'll use the example you may have read a few months ago about a child that was born up in Wausau that did not have a trachea. Well, our ear, nose, and throat and general surgeons, et cetera, were able to actually put in an artificial trachea for that child. Well, we can do that because we have an infrastructure at Children's with pediatric anesthesia and imaging and surgeons and OR personnel that allow us to be able to do that high end. It's the first kid in the United States that was saved, who was born without a trachea. And we do many other things. Well, if we don't do ear tubes and tonsils and all those other things that build our competencies, our ability to do that work, our complex heart surgeries, our cancer care and things like that becomes eroded. And the economic base becomes eroded because you're not going to see a lot of that happening in the central city. It's going to be more in the other markets. And so we really believe to preserve the best interest of children is that we need to have open access to kids. Parents need to be able to make the choice to come up to us and not have insurance products create barriers to children's being in their plan.
So when we're all growing up in this country, we're sort of taught that competition is a good thing. It's the American way. That's what we do. What about healthcare? Is competition inherently good for healthcare?
I think to a certain extent. And I think for the healthcare models today, for the most part, competition can help because the way the system got set up back in the 60s with Medicare and Medicaid, it's basically been on a fee for service. So whatever you do, you get paid for. And do you need to know what the cost is? Well, not really, because insurance covered all of your healthcare and you didn't have high copays and deductibles. Well, in a world that really drives towards value, our accountability towards the cost of healthcare, now that, particularly with us, where we're seeing higher copays, higher deductibles, I mean, there is now a forcing function that is suggesting that we need to be much more mindful of the cost of care, what we charge, and things like that. So I think there is an opportunity for competition in terms of not only the value proposition, but talent, expertise. But there becomes a saturation point because the other problem for the state of Wisconsin is that the population's not growing. In fact, actually the population of kids the last couple of years has been about a 2% decline. And so with no more people moving to the state and overcapacity, if you don't have enough business flowing into your organization, the cost of that is going to go up, and it has to be passed on to somebody, and it's going to be the consumers. So it's a complex problem. So I wouldn't say no competition is good, but I would say competition for competition's sake isn't going to make a better healthcare environment, particularly for kids.
Something else that's changing is the way healthcare is delivered. I mean, that's changed a lot since I was a kid,
Oh, yeah.
which is 100 years ago.
Really.
But tell us about the changes that are coming in terms of delivery systems for healthcare.
I think that where the delivery systems are going to see the biggest change, I think, is, first of all, healthcare institutions are going to bear more risk for the cost of care. And
What sense?
Well, so they're developing insurance products now where you can do joint risk with the insurance company so that you have some stake in the cost of healthcare. So as more of the financial burden transfers to the healthcare institutions, and it's not just the fixer-upper shop where you get paid for everything you do, you're going to design programs and services that are going to step back out to where you give the least restrictive, the least costly type of care, as opposed to just waiting till they come through your doors. And so you see, for us, we're putting clinics out in different neighborhoods. Again, we want people to have access to care. We have 100 primary care doctors to do more in that. The other big change you're going to see, I think, is that in the whole space of mental health, which is one that has been so sorely absent in the healthcare delivery system. I think a lot of it has to do with people's perception of mental health. But 2/3 of the kids in the central city of Milwaukee grow up with significant mental health issues. So I think when you start to look at what is the delivery systems, I think you're going to see it more external, and people are going to invest more in that. And then I also think that it's going to be a broader suite of services, dental health, mental health, and some of these other things that basically haven't always been seen as part of health care.
Mm-hmm. I want to spend just a couple of minutes talking about Peggy Troy's background here, and I mentioned that she's a Marquette graduate from the nursing school here and went on to get her master's at DePaul.
Mm-hmm. Yes, I did.
But she began her career as a neonatal intensive care unit nurse. And I'm wondering how that experience, and it has to, how that experience informs the way you carry out your duties in a very different job as CEO and president. What was that first experience? Being in those life and death situations, how does that affect you?
It gave me a perspective of patients and families and what they really need. I mean, so I know what it's like to be at a bedside. I know what it's like for a family to have devastating news of an outcome for a child that really requires that you do so much more for the family than just fix the problem that the child has. And it also you also learn systems of care because when you're at a bedside, you depend on environmental services, you depend on the maintenance team, you depend on respiratory therapists and nurses and pharmacists, and so your sense of what it takes to make all that work well in the best interest of the families and the patients you're trying to serve, I have firsthand knowledge of that, and I haven't forgotten about the importance of that. And then just the support families need, because as I said, nobody wants to have a sick child, and so what it takes for us to holistically wrap ourselves around those families, I have a keen sense of the importance of all those other services that, whether it's a Ronald McDonald House or our social service department or pet therapy or whatever it happens to be, how that adds to the patient experience. We believe kids deserve the best, and yes, we've got to give the best technical care, but there's so many other aspects of it, and I think back to those days about what it was like at the bedside with those families.
Could you see this day when you were running a major?
No.
I mean, because most people, people have a vision. They have dreams of what they want to do, what they want to accomplish. That didn't seem like it was possible.
No, in fact, there was a point that I thought I'd be a nurse practitioner. So I was really headed more towards that road, and just fell into a situation when I was at Lurie Children's in Chicago where I was asked to be put in an administrative position. And I never turned down an opportunity, so I did it, and I went to graduate school, and that's what I did. And I love it. I really appreciate it.
You interned at Children's Hospital.
I did. It was while I was in nursing school, but then also it was my first job. And so I had, and it was over here on 17th in Wisconsin in Humphrey Halls. It was pretty bad, yeah, worn out, tired building, but we did some really good care there. So yeah, it was, and if I'd ever thought, I actually met my husband at Marquette. He's out sitting back there. And we went to Chicago, Texas, Tennessee, and then came back. And we're really glad to be back here.
Life's funny.
Life's funny.
Well, you never know.
No,
You never know.
Like I say, when I was sitting in the union at Marquette doing whatever I was doing, wouldn't have been here.
So a couple of thoughts about servant leadership, because I know that's a term that you use fairly frequently. It's a concept you believe in. So for all of us, define servant leadership and how that drives you and how it drives Children's Mission.
Well, to me, servant leadership is you're there to serve. It's not about you. It's about what you're able to do. And I think the best way I can describe it is that my father was a general practitioner, and he was the town doctor. And so growing up, I got to see servant leadership at its very heart because, I was able to see how he served families, and he was there for families, and it was never about him. He was a very humble person. He was very, had a lot of humility, but whatever a person needed, whether it was stitches on a Sunday afternoon because they got a fish hook, or going to see a sick patient in the middle of the night, going to deliver a baby, you get inspired by that, and you start to meet when I was in school, I was able to work in his office, and I got to hear the stories of families that my grandfather was the first doctor to move to our town, and my dad took over his practice, about just what that meant for them to serve their families and how important that was in their lives. And so it was really, I think, the modeling that I had that showed that, this isn't about you. It's not about your success or your career. It's really about helping people and doing the right thing and being there for them. And Marquette's a wonderful foundation for that. I mean, I love the term be the difference because that's what you're there to do, is be a difference, but not for your own self-serving capabilities.
Mm-hmm. Let me bring this full circle, and then we'll take some questions from the audience. So as you look ahead and you look into the future and you look at what this community is, what it could be, what would be your wish for us as a community so that we can realize, I think, the potential that all of us feel Milwaukee has?
Do a better job taking care of our kids and let them grow up in an environment that allows them to achieve their full potential. I mean, that to me is what drives me every day. So how we array programs and services and education, policy, just really thinking about the kids and really remembering that they are our future. They're the ones that are going to make us what we are, and just making sure that they're not forgotten.
We do talk a lot about it, very honestly. Do you think we walk the walk?
My observation here, Mike, is that we do a lot. There's so many good things happening. There's so many wonderful foundations and so many wonderful people that are willing to put skin in the game. It's the best community I've been in terms of the willingness. I think the problem is that the way that that's happening is not in a holistic approach, and that there's categorical funding that goes for different pieces and parts, but really stepping back and looking at, okay, how do we do this in a much more integrative way so that the impact is so much better? So I find people very generous, very willing, but the partnering and the wisdom. United Way teen pregnancy is a great example, where the United Way went to agencies that they knew had the competence and capability to help us reduce the teen pregnancy rate, and then put the funding into those programs that they knew were going to be value add as opposed to one-off. That's a best practice, and that's what this community can do, and we've got to keep driving it because there is a lot of conversation about the how.
And children's future. You feel it's a bright future?
I feel it's a bright future. We've got so many wonderful things going on. We're a treasure in this community, in the state. We have so many people that give us gifts of time and treasure. I worry about Medicaid when you realize that it's core to our success because of the conditions kids find themselves in. I'm very worried about it.
We've got about 20 minutes left, and so I'm going to open it up to the audience for questions. If you are in the seating bowl down here, some of you know this, press down on the rim, not on the ball, but keep your finger right down on that rim. We'll be able to hear your question. If you're in the back and you have a question, we'll wait for Ryan to bring the microphone over to you, and then we'll all be able to hear your question. So please raise your hand if you have a question for Peggy Troy. This is amazing. We answered all the questions. Yes, sir. Yeah.
I was wondering, being on the campus that you're on, what kind of synergies does that bring to the Children's Hospital?
That's a great question. And so there are many synergies. We have the Medical College of Wisconsin that's out there, the Blood Research Institute, and Froedtert Health. So what that does is that we are one of the largest pediatric training programs in the country. And those trainees value education and research. So our partnership with the Medical College of Wisconsin allows us to have amazing, groundbreaking research, some of the best educational programs in order for us to survive. They also, Medical College employs all of our specialists, so we've got about 500 of them. And so they work exclusively at Children's, but they are employed by the Medical College of Wisconsin. So we jointly share in how that's funded in order for us to continue to have the best and the brightest. Our relationship with Froedtert is interesting as well. So one real wonderful thing in our community is that Froedtert delivers babies, but their OB unit is inside the walls of the Children's Hospital, literally down the hall from our neonatal intensive care unit. So we are a perinatal center, and so if moms and dads come in and they have a high-risk infant, they're able to have access for that baby to the best care right there in the delivery room. Now we do fetal surgery, fetal interventions, and things like that because we're right there. We're also a level 1 trauma center where any child who has a traumatic injury can come to our doors. We're that because the types of services we need to have 24 hours a day, 7 days a week, like hand surgeons, are available to us, whereas a standalone children's hospital, not many people have hand injury, kids have had, so we've got availability for that. And then the Blood Research Institute is a fabulous partner because of the research there. So when we're looking at hematological cancers and things like that, we've got a partner. So there's economies of scale by us all working together, even though we're all our own independent 501c3s. And I have the belief that that campus could be something so much more than it is. Marquette's now come out with the School of Biomedical Engineering and others so that it could become a very important tech center. But that's where the community needs to come together and say, okay, we've got this asset, let's really make it be something that to make the whole region much more prosperous.
Let's take other questions. Yes, sir.
I was wondering, you spoke about competition in Wisconsin. I was wondering more broadly about, if you could talk a little bit about whether there is active collaboration among the major children's systems throughout the country. You mentioned Lurie several times down in Chicago, but is there active collaboration amongst the children's systems?
The one area that we actively collaborate is on advocacy. And so, like I said, we're very active in Washington, D.C. We have a common agenda, and so we work together. The other area that really in the last several years has come to be an amazing collaboration is around safety. So there's about 123 of us in a national collaborative driving towards eliminating harm, because we know that bad things can happen in hospitals. And we work very well together as institutions to try to look at what are the best practices. And in fact, we've reduced overall harm to kids in a hospital by about 70%. But that's taking information from others on hand washing and all sorts of other things that can happen and really driving that down to zero. And then the last area we really do a great job collaborating is in research. So, and I'll give you one example. There's a national organization called the Children's Oncology Group. Childhood cancer is relatively rare, so no one of us alone can do enough research on kids that have certain types of cancers. And so it all, all the research funds or the data goes into a central repository, and then the scientists can use that to look at better ways. So if you look at the cure rates in leukemia, for instance, several years ago, it was kind of a death knell. And now, if you have acute lymphocytic leukemia, your cure rate is over 95%. So that's, now, on programs and services, we need to do a better job on that. When we do some collaborative work, but I could see a day where the children's hospitals in a region are going to have to come together in a much more impactful way. And in fact, we've got several conversations in our region around things like fetal surgery, where you might not see very many, but can do some very compelling work.
Other questions? Let me go back here. We'll go to that side of the room. Hang on a second. We'll bring a microphone. Yeah, just a second.
That's okay.
Because it's being recorded and just want to make sure everybody can hear it.
Can you hear me? Okay. Yes, I can.
Yes.
You spoke about you do foster care and adoptive services. Now I know that there's a state agency that's part of that.
Yes.
Have you ever looked at possibly you should be the single provider for all those services and get the state out of that business? Wouldn't you probably be doing a better job and convincing the state that they could save money? In the long run, obviously, getting children out of dysfunctional situations into, if they have to be adopted, probably saves the state a lot of money over the long term. Have you ever explored that or even thought about that?
Well, we haven't. Really, right now, the state's role is a funding agency, because in the 7-county area, there's 2 organizations that do this, in St. A's and ourselves. So the state really is the funder and then the overseer. I would say there's some better ways that the money could be spent for us to be more efficient and effective. So there's still work to be done, but with that said, we have a good relationship with the state agency, the Bureau of Child Welfare, and we are working through ways in which we can improve that. We're working on it.
Mm-hmm. Other questions? Yes.
What do I do?
Just press down on the rim, yeah.
All right.
We'll get you.
So you talked about how factors outside of the home really impact children's health. How are you guys looking at nutrition in terms of impacting children's health, and what we can do to improve nutrition and access to quality food?
Everybody hear that?
About nutrition?
Okay, good.
Yeah. So in our neighborhoods, the 4 neighborhoods we do work with grocery stores and other community providers of food to make sure that there's access to fresh food, et cetera. I mean, the cost of banana is more than a bag of chips. So, you know, how it all works out. We really also, so we work with the kids when they come through the doors and do a lot to teach parents about cooking fresh food, about buying fresh groceries and the meaningfulness of that. We really work with the community agencies, Growing Power and others, to try to make sure that they have availability for food in the neighborhood. So obviously it's a huge part of kids' health and health outcomes. But that's where we've got the partnering opportunities, other than the kids that come through our doors like diabetics and things like that.
Mm-hmm. Other questions?
One back there.
Oh, yeah, I'm sorry. Yeah, Robin.
You've spoken about a lot of things that are very, very concerning, a lot of issues that are very, very difficult. And I'd like to hear, if you could flip it, for you to tell us of an experience or an issue that is, for you, very inspiring and speaks to what you see as the hope and the link to your guiding star.
Well, so first and foremost, in terms of the care that we are able to render to kids when they're inside the walls is very inspiring. I think that the success that we've had in a couple of our neighborhoods is very, very inspiring. And so one I'll note is Metcalf Park, which is one of the highest crime rates in the city. So what we were able to do when we went into Metcalf Park, which the Next Door Foundation resides in, is we worked with Housing and Urban Development, we worked with the police department, et cetera, and started to really look at what are the drivers, what's impacting those communities, housing, crime, et cetera. And actually, if you read in the papers recently, there was about a 43% decrease in the crime in Metcalf Park. Part of what we did is we held community cafes and talked to neighbors about what really was driving some of and what we always start with the question, what matters to you? Because we can decide what we think matters, but it's really important to them. And so as we started to engage the community, engage some of these other agencies, because again, so much happens outside of what we do, you know, people are now actually walking outside, and the crime rate's lower, some of the immunization rates are higher. So I see that as a kernel of a neighborhood approach that actually produced some very positive results. And how you replicate that, you can't, it's not a one-size-fits-all. Every community has its own little culture, and so you've got to fit within that culture and not just assume you know the fix. And we're doing that in 3 other neighborhoods. So I see great hope with that. And when you see teen pregnancies going down and infant mortality and some of those other factors, that's the hope message.
Other questions? Yes.
You may have answered this already, and I just didn't hear it, but Alverno College has a program where unwed mothers are able to get babysitting services. Is Marquette University big in that area?
I don't know. Janet?
I think we have a fair amount of community services, but I'm not sure we have one central service for that. My partner's over there.
No.
I think we have a lot of, we have a lot of community connections in a lot of different areas throughout campus.
Other questions? Yes, Carl.
Given that you have 50 locations throughout the state, how many of the 72 counties do you cover, and where do you see the holes in that network?
So I'll tell you that for us in the 7-county area, we have a huge footprint. And so some of that are clinics, primary care offices, and a lot of those locations are child abuse prevention, treatment, well-being sites. As you go out is where you really start to see the gaps, and particularly in northern and western Wisconsin, where there's not a lot of people, is where it's most significant. So in the more densely populated areas, there's a good infrastructure of services, but it's limiting because there's not as many kids, there's not as many agencies that partner in order for us to do that.
Other questions? Yes, sir.
How closely do you work with the Bureau of Child Welfare to do preventative work? We read about kids being mistreated, and you get them after the fact. Is there anything that Children's can do to help the social workers with the Bureau of Child Welfare prevent some of the things we hear about?
Yeah, that's something we're very active in. We have, like I said, in our child well-being team, we have about 500 social workers, and a lot of what they do are in-home services, so we're not waiting till the kids come to us, but if we find that there's a family at risk, we have 11 school nurses and community navigators that help us identify, and so then we can use our social workers to go in and do home visits and be there for the families, determine what is driving some of the disruptions and try to prevent in that mechanism. And and Bridget, correct me if I'm wrong, but the Bureau of Child Welfare really is more about child abuse services once those kids are identified. So, but we're investing in pushing that out.
Time for just a couple more questions. Yes.
Jackie.
Hi, Peggy. Talent management seems to be at the top of everybody's list in healthcare. The delivery system's changing, technology's changing. There are few of us going just population health. Can you just talk about what children is doing about talent management and what the concerns are? You're sitting in an academic institution.
Well, I'll tell you one thing that really worries me. The average age of a nurse in the state of Wisconsin is 53. Okay, so for all of us boomers who are aging, we need nurses. So, yeah, we need.
The average age of a faculty member in nursing is even older. So.
Yeah. So
58.
58. And the predictions for the state of Wisconsin in terms of physician shortages is about 4,000 in the next 10 years. So we do have a need for talent. So at Children's, one of the things that we do in our 5,000 employees is we really work on our culture because our work is hard. Healthcare is, scary right now, and really assuring that we have a culture that attracts good people, but then takes good care of them and allows them to do their very best is one of the things that I'm very personally and deeply committed to. So we're blessed in that we have a pipeline coming in. We don't have a lot of vacancies and our turnover is very low, but we never take that for granted because our asset, our product is our people. They're the ones delivering the service, and so when you look at what influences people's perception of your care, you know, are their hallways and rooms clean? You know, do you have a smile on your face, et cetera, et cetera. So I think the main ingredient for talent management is, yes, we've got to have the academic institutions training the people, but you can attract them and have high turnover rates if you don't have a desirable work environment that make people feel that they can come and do their best work. And so looking back at Tricia, one of the things that we've branded at Children's is a program called At Our Best. And we're making major investments in people about themselves, not just come to work and do the company thing, to assure that they feel healthy and well taken care of to do their best work. Because we think kids deserve the best, and we have to be at our best.
There you go. Yeah.
Thank you for your good work. Kind of the monster in the room is the larger socioeconomic disparities in our community. And you've alluded to the loss of jobs and that sort of thing, but we're worse than many Rust Belt cities even. And I'd like to hear from where you sit. What is happening in our community, and how do we come together around our children?
Well, the one thing I will say is that there's no shortage of well-meaning people that are willing to put dollars and time into solving problems. I think some of the factors are, one, we're digging ourselves out of 4 generations of poverty, and so there's not a quick fix down the road. I personally believe that investing in our kids early is a big part of the solution, but we've got issues around, and we're trying to solve the access to healthcare, our educational systems. I mean, when you look at the performance of kids graduating or reading at 4th grade levels in 4th grade is low. So it's a multifactorial. It's jobs, it's schools, it's neighborhoods that kids can thrive in. And so I would say it's multifactorial. I'm looking over here at Susan, who does a lot of work in this, and I don't know that there's a one fix for that, but I know the Zilber Foundation is working tirelessly on some of these things as well. Do you have anything to add, Susan?
I think your comments about digging out over 4 generations of poverty really is at the crux of the matter, recognizing that we have to address the larger context as well as the needs of the individual child. So your wraparound services that are provided at the community clinics, the health navigators who do door knocking to hear what people need, all of those things I think are part of the answer.
Time for one final question. If it can be brief, we can get to it. You bet.
What do you see as the benefit of being a part of the Milwaukee Healthcare Partnership?
Well, so the Milwaukee Healthcare Partnership Council is a group of all the CEOs of the largest hospital, or all the hospitals in town coming together to try to solve community problems. For Children's, the biggest benefit is helping people enroll in programs and services that are available to them. And then trying to develop systems of care for specialty services, mental health services, and things like that, that really try to address some of the problems in access that we have in the community. So one of the things that we do is we help fund the federally qualified health centers, which are so important. And because it's really important that for those centers that they are placed in communities that allow access to care. We've got 5 now in Milwaukee, and those are comprehensive organizations that, from everything from mental health services, dental care, et cetera. And so I think our partnering with you and funding is a big help for you to do all you do.
I'm going to wrap things up there. Before we go, a couple of words. We're getting near exam time here at the law school, so this building's going to get pretty quiet. So we won't be doing events here for the next couple of weeks. We did add, though, a couple of events, and They have not been posted yet, but there'll be one in late May and one in early June. So the On the Issue series will continue for a while longer. So check our website, law.marquette.edu, for the very latest on that. I just want to thank everybody again for their time, their interests, their attention, and most of all, I want to thank our guest today, the President and CEO of Children's Hospital, Peggy Troy. Thanks very much for being here.